Perhaps Professor Stratάκis will give the lecture in English if you
Are you
stay
staying?
here.
If you stay, then yes. If not, I'll do it in Greek, whatever.
Okay.
Okay.
So this is the last lecture, and this is the last lecture from a best man. Is Professor Stratάκis. There are so many titles that I can give in order to present you, but I will stay with one of the best scientists in our times. So Professor Stratάκis will give a provocative, I think, or I hope, lecture on ART and genetics.
Thank you so much for the nice words. And I think the most important role I have is that I'm the geneticist of Mitera IVF. So that's, I think, the most important role I have. So you asked me to talk about ART and genetics, and I'll do so. Of course, it's a huge issue. And what I've selected to do is I've selected to, first of all, I asked, what is the biggest genetics problem that we face today in ART? So I'll try to give an answer there. Then, obviously, I enjoyed very much the discussion about AI, because there's some things that I want to touch on, and maybe from my experience running a lab for many years to see how this will be implemented. And then finally, show the newest developments in genetics. I'll show a few things that have only happened in 2025. This is a rapidly evolving field. Okay, so these are the processes of ART. I don't want to go over them. And so the question is, in genetics today, what is your biggest problem? So I'm thinking, and maybe I'm wrong, if I'm wrong, correct me, that your biggest problem is how can you use genetics to identify the best quality embryos? It's exactly the discussion you were having before. And so I looked at what is there. This is a review article at Fertility Sterility just published last week on my birthday, on November 5th. And it says, nearly 5 decades after the birth of the first IVF baby, the embryology lab still depends largely on manual, experience-driven techniques shaped by earlier technological constraints. So the most rapidly advancing frontier is embryo selection. And so the question is, how can we improve embryo selection using the newest technologies in genetics? And it makes sense to use the various omics. What is that? This is, of course, DNA. That's old. DNA is now, it's amazing if you think about it. We can sequence DNA for 40 years now. We can sequence it for 60 years, but for everyday purposes, it's basically 40 years since PCR. That's it. We've only been sequencing for 40 years. But if you think about it the other way, it's a 40-year-old technology. So you can't rely on a 40-year-old technology to get the best results, because you tried it, and you haven't been getting good results. So let's see what else. Instead of relying simply on DNA sequencing, then you go on and you sequence RNA, and you go on and you determine proteins, and you go on, try to correlate the data between DNA, RNA, and protein. And that's what omics is. So we can then, if we have this data, improve on the monitoring. So I'll just take an example. Now, so this is not embryo selection, but it is a paper that is published by Dr. Lee in Korea. He's very well known in South Korea. And he uses exactly what I just told you. He uses omics from the culture fluid. He obviously images the embryo. He uses all the DNA sequencing, and he feeds into an AI-based module so that he can give you the best quality embryos. Similar technology is used for the improvement of the various substances that one can use to improve anything from fertility in the male and the female to the culture media. So this is a Chinese paper. Again, I'm only showing papers in 2024, 2025, because that's, you know, things are moving so fast, there's no point in going further back. So this is a paper using this traditional Chinese decoction, the kihusi, and trying to see whether they can improve fertility by using this. And look at the methods they are using. It's exactly what I told you before. They sequence fully all the data, all the material, both for DNA, RNA, and determine protein to come up with the best, technology. So AI-driven precision treatment of reproductive medicine-related diseases is what is the future for the optimal protocol choice for IVF, and it will look something like this. In other words, you get, I think you referred to it, and I think you said you have a lot of data here. So this is how your screen will look like to feed an AI-based system that will give you the predictions that you were asking before. Am I following the right protocol for the right embryo? Am I implanting at the right time? And what are my best chances of success in this pregnancy? This is all going to be answered by using the data and what I just told you, the AI. Now, having said everything I just said about how important new technology is to understand embryo selection, I was very impressed to read the very next day after my birthday, on November 6, 2025, this paper in the American Journal of Human Genetics. This paper in the American Journal of Human Genetics refers to something we all know for more than 40 years, that one of the biggest failures of IVF, one of the biggest failures of human pregnancy, human conception if you want, is aneuploidy. And the question is, why would a paper studying aneuploidy be published in 2025 in the best genetics journal? This is the American Journal of Human Genetics. The reason is that even today we still don't understand. It's very important for embryos that will be cultured for many months before implanted. So we just heard that most likely embryos will be in the lab for 2-3 months. Pregnancy will be short, 2-3 months maybe. But in order to do that, you need to understand the chromosomal dynamics. So it appears that only now we understand what this paper reports, which is that haploidy, so defects in chromosomal number, but that are at the chromosome level, are almost always from absent sperm. So if you have 45X, it is absent chromosome from the sperm. If you have 47XXX, almost all triploides are from maternal meiosis errors. We didn't know that. When I read the paper, I went back to my notes from older papers, and I hadn't realized that it was so simple, that every time you lose a chromosome, simple ploidy defects, those are all sperm defects. Every time you add a chromosome, these are all maternal defects. And so in this paper, this is the diagram from this paper. They looked at, here is the power of data. They looked at 20,187 IVF cycles. And obviously they used PGTA, and they used PGTM for monogenic, but for the terms of the chromosomes, it was PGTA. And you can see very clearly in this diagram, I don't know, the pointer doesn't show here, but you can see where the ploidy for sperm and the triploidy for oocytes. And very clearly, so that's knowledge that we already knew, this aneuploidy for oocytes was very well correlating with the age of the egg donor. So many questions remain. can we improve on DNA yield in non-invasive pre-implantation genetic testing? And I don't know whether you use that. Have you used non-invasive genetic testing? So there's more and more papers. This in 2025, we think that probably in the next year or two, the testing will not be invasive anymore. But one of the biggest problems is the accuracy of the method. So you can see this is a paper that was, again, published within the last 2 months and looks at all the data from many pregnancies on non-invasive PGTA. You can see there was a high concordance rate between invasive and non-invasive, but there were a lot of false positives for the non-invasive. Now, one of the biggest problems is when I give you a PGTA result, whether you can proceed or not with using embryos, certain embryos. I was very impressed when I read this paper. Again, this came out in Fertility Sterility a few weeks ago. All embryos here were abnormal by PGTA. And yet, because this was a unique situation for the family, the gynecologist decided to go ahead with implantation. And here we are. There were healthy euploid dizygotic twin birth after transfer of non-mosaic but completely aneuploid embryos. How did that happen? Well, I guess I have to say here the gynecologist was very cavalier by doing so. It was obviously a unique circumstance. But what the gynecologist took advantage of is an old phenomenon we all know in genetics, and that is placental rescue, right? Every time we have an unemployed conception, what does nature do? Abort the conception. When the nature, for whatever reason, or God, whatever you believe in, tries to preserve the pregnancy, what does it do? It creates a mosaicism in the placenta, and then during the fight between normal and abnormal cells, the normal cells usually win, and you have a mosaic placenta, but a normal euploid embryo, and maybe one. I mean, it's almost certain that this embryo has a small percentage mosaicism, but it's non-perceptible and not clinically significant. So this is what happened here. There were babies born normally out of these aneuploid embryos that almost certainly due to the placental rescue phenomenon. So here is a challenge for AI. AI would, at least today, could not have predicted this. Because you would have to give to the AI, to the ChatGPT, you will have to give biopsies of the placenta with exact chromosomal constitution to be able to predict what are the chances to develop a normal embryo. So there's a lot of challenges that remain for the prediction of a good quality embryo. Okay, a big frontier in genetics today, and this is something that I'm dealing with you guys every day when you call me to consult on a couple that he wants to use a donor. A big issue is the genetic study on candidates for oocyte donation. Practically every society in the world has their own guidelines on to what extent you can do genetic testing. Obviously, parents, and this is what this slide says, you can read it. My slides will be available to you if you want to get them on a PDF. But basically, different societies allow for different levels of screening of the egg donors. I practice in the United States as well as in Greece, and I can tell you that in the United States, you can do practically anything you want. Most wealthy couples can screen the donor for anything they want. And one could argue this is eugenics. This goes beyond what anybody would ever do for screening gametes. And so I urge you to look at this paper. This is 1 year old. This was published in August 2024. It's a 5-page paper, Infertility Sterility, about the pros and the cons of extended egg donor genetic screening. Very, very balanced review. I urge you to read it. I'm not giving you answers. All I'm saying is that it is an expanding field. It's an issue that I deal with every day. It is interesting to me how Greek couples are so informed, and they go after and they ask Dr. Stratάκis, where can I get 5,000 genes? Where can I get 18,000 genes screened? And so forth. They really want that. And then I have to negotiate. So, but the ethics of this are truly troubling, because it is essentially, as this article says, a new form of reprogenetic selection. And so this is from this article. Again, I urge you to read the Fertility Sterility Review and this one to understand better this issue. Okay, so there is an expanding genetic screening for donors. What about embryo screening for polygenic disease? Okay, so far we are all screening PGTA, aneuploidy, PGT-M for monogenic disorders. It makes sense to screen for thalassemia, right? Of course. What if I say, well, my family, everybody in my family had a stroke because we all have hypertension. And we've gone to the geneticist and we've checked for monogenic causes of hypertension, and I have none. I don't want my embryo to be hypertensive. So, okay, so today in the United States, there are services where you can screen the embryo for what is known as polygenic disease risk, or PRS or PDR. So, is this reliable? It's done. It's being done. Couples pay $5,000, $6,000 to screen by PRS for common diseases. PGT-C, not PGT-A, not PGT-M, PGT-C, common disease. And does it work? Okay, it's interesting. So this is a study just published looking at whether the PRS, the polygenic risk score, works for certain diseases. For breast cancer, and you look at the baseline is the ratio of 1, so it works. And if it's better than 1, it is more accurate and if it's less than 1, it's less accurate. And you can see for breast cancer it works. For hypothyroidism it works, but it basically doesn't work for anything else. For hypertension, for metabolic syndrome, for strokes, it doesn't work. Now, why does it work for hypothyroidism and why does it work for breast cancer? Well, because there is a greater contribution of single gene mutations for breast cancer, and there is very well-known genes for hypothyroidism. That's why we do congenital hypothyroidism screening, because we have the genes, we know the diseases. But for any other disease, for hypertension, for stroke, there's very few single gene disorders that you can screen for, and the PRS doesn't work there. So you can see here from this paper, what would the percentages be of random selection in black and using PRS, the genomic index selection. You can see in breast cancer, what I told you, the difference is only 15%. But for metabolic syndrome, it's essentially toss of a coin, 40%. So why would you use PRS? So, but still, it's being used today. All I'm saying that today, scientifically, for most diseases, you can't do it. And this is what this paper says, very, very well-written paper. Polygenic risk score for embryo selection, not ready for prime time. Will it ever be ready for prime time? Probably yes. I mean, we are all using PRS now for longevity. So in my clinic, I do PRS for common diseases for people that want to improve on their health. And the data are pretty good, but they're not as important as selecting an embryo. So it will probably be okay in a few years, but not yet, not in 2025. And then I'm finishing up with really what is, because I'm a geneticist, but I'm also a pediatrician. And it's really an exciting time to be a geneticist and a pediatrician and work with you guys, because now when you diagnose a genetic disorder in utero, for the first time ever in the history of medicine, you can treat that disorder in utero. So in utero therapy is the next frontier. All the papers I'm going to show you have been published in the last few months. So this is the first in utero enzyme replacement therapy for infantile onset Pompe's disease. This was published in New England Journal of Medicine just 3-4 months ago. You can clearly see this couple had already lost 3 children due to Pompe's. The fourth one, the one in black there, female child, was treated in utero with enzyme replacement starting the 3rd month of pregnancy. And you can see how good the numbers are. So this is the one in green. The other 2 embryos are the ones that were lost due to the disease. And the one that was treated early in pregnancy with in utero enzyme replacement survived, is now almost 2 years old, and is doing very well. Along this line, so this was the first in utero enzyme replacement of a metabolic disorder where an enzyme was needed. So now SMA, as you know, the FDA and the EMA, the European Medical Organization, have approved now therapies for infants with SMA, with a severe form of SMA. And the question is, if you have a couple and you diagnose the SMA during pregnancy, can you do something about it so that you can prevent the most of the complications? The answer is yes. So now there are 4 trials ongoing in the United States where practically the same technology used for newborns with SMA is now being used in utero for SMA. We don't treat the forms 2, 3, and 4. We only treat 0 and 1. Obviously, the SMA, the most severe form is the prenatal. This is the famous limp baby, born not moving at all. And the babies where SMA starts before 6 months of life. So these are the 2 stages that are recommended for in utero treatment. And these are the 3 available medications that have been approved. Already the first one in 2017, the last one in 2022, that have been approved for ex utero, for the first year of life. And the last one on this over there with red is the trial that's ongoing for in utero use of one of the 3 treatments for SMA that I showed you. This is this one. So this is from February 2025, New England Journal of Medicine. It's one of the 3 that I showed you before, Risdiplam for prenatal therapy of SMA. And it seems to work. So far, 2 kids have been treated, and at least one of them remains free of symptoms of SMA in the first year of life. So I'm certain that patient-specific in vivo gene editing to treat a rare genetic disease is happening. Obviously, we want to use prevention, and hopefully less and less couples will have babies with a serious disorder. But if you do have a serious disorder, it can be treated today, and there is no question about it. Now, everything I've shown you so far in terms of in utero treatment relate to enzyme replacement when there is an enzymatic deficiency, or oligo treatment, which is the treatment for SMA. What I have not shown you is in utero gene therapy. Okay? So this is slowly happening. This year, there was a trial in babies with cystic fibrosis to use practically the same technology that's being used ex utero later in life, to use it in utero for the avoidance of meconium ileus, because so that way you can prevent that in babies with cystic fibrosis. And there is this trial, the PEARL trial. It's ongoing for lysosomal storage disease. So I'll finish up with this picture that was published last week in Nature. ART is doing miracles, has been doing miracles now for half a century. There is no question that we are living in exciting times. In these 25 minutes, I try to go over things that I think are exciting, including what I think is the most exciting, the technology that improves embryo selection and the in utero treatments. But ART is being used for many other things. And this is the rhino up in Siberia that is now being saved from extinction using ART. And this picture was one of the 10 best images of the year in Nature, published last week in Nature. So thank you very much. There's clearly a convergence of technology from various fields in omics, as I said, for the use in ART. There's no question that the use of AI will revolutionize ART, and therapeutics, as I showed you, will benefit from both AI and gene editing. This is where you send me your referrals, and I thank you for that. I thank you for the great collaboration we had this 1 year since I joined your unit. This is my academic lab, and I want to thank here all the funders, including the National Secretariat for Technology here in Greece, and my academic lab in Crete. Thank you.
Thank you very much, Professor Stratάκis. That it was excellent speech, very intriguing and fascinating, I would say. But my feeling of what you've shown is that we are just about to open the Pandora's box. And the fear is whether we are very close to enter the door of eugenics. Mm. So, and I would like your opinion about it. I'm afraid that in the near future, ethicists, politicians, societies will have a lot of work to do and will very many dilemmas to tackle.
Well, I mean, clearly this is, the technology is there to select the perfect baby. The problem is what we call perfect may not be perfect, because we obviously are not gods and we don't know what is perfect. So that's problem number one. Problem number two is that, yes, you can select your perfect baby, but you do it at tremendous cost. And that means that it's not equal to everybody, because not everybody can pay thousands of dollars to get the perfect baby. So there's equity issues, there's ethical issues, but because the technology is there, we cannot close our eyes and say, oh, you can't do it, it's unethical. No, no, no. You have to, we have to, all of us, citizens that are not physicians, us as biologists and geneticists and gynecologists and physicians, everybody has to get together to come up with reasonable guidelines that will allow the technology to progress, but will not lead to ethical monstrosities, because clearly there is the possibility for ethical monstrosities. That's all I can say.
Any questions from the audience? Dr. Karatsis?
Kostas, congratulations, and it was a really privilege to have you among us in this first Congress of our unit. I do agree with what you just said. I believe, with due respect to Dr. Masrominas, as the technology is sitting there and we can take advantage of doing things and treat diseases that is tormenting families or patients as individuals, we can't close our eyes and well, expect that some dark mind will decide to go further and create the perfect human being. I believe that we're the margin at of a new era, and I believe that we're very lucky people that in our age will experience this tremendous development in genetics, and that goes hand in hand with IVF. Thank you again for this.
Thank you for the kind words. I wanted to add to what we were discussing now. You know that you can clone your dog and your cat, right? It's for $50,000. You can get your dog cloned, and for $30,000, you can get your cat cloned. So, I mean, it's a simple order on your computer, and you send the DNA, the company, I know them, they are in Miami, and you get your cat, and you get your dog within a few months, no questions asked. So you can see that society has already accepted that a being, it's not a human being, but still a mammal, that you actually, most of us feel are part of our families, right? So when a dog dies, is a part of our family that is dead. So we have accepted this. Just I wanted to make sure that you all know this, that you can, today, you can go on your computer, I can give you the address, it's $50,000, so it's fewer euros, for a dog, 30 for a cat.
But
yeah, well, that's...
Sorry, but this is a huge difference between having a dog, you know, identical to your dog, and it's completely different to kill babies who might suffer from very, very light diseases, for instance, short-sighting.
Yeah, absolutely, you're absolutely right.
Or, you know, hypothyroidism. We are not talking about lethal diseases. We are talking about absolutely,
let me add to what you're saying.
So you have 10 blastoses, and you kill 9 blastoses to have one which is absolutely perfect. I think this is terrible.
I completely agree with you. The other thing that people need to think about is the value of being a carrier of a mutation. Mutations are there for a reason. It is the tool for selection. It is the price we pay as we evolve as beings. Therefore, especially for the frequent mutations, most likely they offer an advantage. And I'm so devastated when I explain to a couple that all you have is a carrier state. That means nothing for you. It probably means certain good things. And yet they say, no, I don't want my baby to be a carrier of this disease. So we have to educate our people to understand that mutations, we should change, but by the way, we shouldn't use the term mutation, right? We should use the term variants. Number one. So it's not a mutation, so people should not be afraid of mutations. These are genetic variants. Small changes in the DNA that make all of us different from everybody else. Number one. Number two, there is a certain benefit for carrying certain variants. And that is why some of them are so frequent, right? For example, the variants that retain salt in African Americans. They come from Africans that back before they migrated to the United States, to the Americas, had to retain water. Of course, now in a salt-replete society with plenty of water, they become hypertensive. but it had a benefit in another society. We all know the thalassemia and sickle cell disease carriers. They don't get malaria as frequently. So there is a benefit to being a carrier of a variant. And yet, you know, that education, I think it's very important when we talk to our couples to understand that not every change is bad.
Lecture. Great lecture. Israel is very advanced in the sense of genetics because Ashkenazi Jews always had a higher frequency, and when we started 30 years ago doing Taizaks, we had one, and then we would tell the population, where do you come from? If you're Greek, you have to do Jewish Greek, you have to do this. If you're non-Jewish Greek, you have to do this. We give this consultation. This became really complicated because in Israel, every Arab village has a certain mutation. So now, from this year, the government is asking all patients to undergo 600 mutations, which are prevalent in Israel, for free. So there's no cost issue anymore. Of course, they made the calculations that it's much cheaper to do this wide screening for free and not to treat the babies. And to your comment, it's very complicated. You know, BRCA is very common among Ashkenazi Jews, and everybody's afraid of breast cancer. But actually, more people die from diabetes and from genes related to diabetes than from BRCA. So if we had to do embryo selection, and if we knew how to reduce, that's a different issue, but maybe in the future, diabetes is much more lethal than being in BRCA mutation. So, and again, in Israel now, all our patients are doing exome tests when they do amniocentesis, which is $3,000, and they all do a 2-year test, which they check their parents. And now we're getting sued if we don't do the exome, because I'm now getting sued because I had twins who did, of course, amniocentesis, but they didn't do exome because 8 years ago nobody did it, and the baby was born with a mutation of Rett disease, which is severe. And now they're saying, why didn't you in 2016 do an exome test? So I'm saying I can tell you about the future. The future is coming fast because everything that's happening in Israel happens 5 years later in Europe. So, and now they're telling us, why do you do an exome? Why don't you do a full genome? Because we're missing something, and then we don't know how to interpret the full genome anyway. So first, again, I'd like to thank you for a very interesting lecture, but these challenges are nothing we can escape from. Everybody wants a healthy baby. People are willing to pay a lot of money for a healthy baby, and I think we're in trouble. We'll have to do more and more wide screening. And again, if you look at Israel, the government is paying for it, and this means it's also a game changer because it means we cannot start treating IVF before they finish the screening, because then they will get sued. Why didn't you do PGTM if you had waited for the results? So life is tough.
Thank you. Toda.
I agree that the future is coming fast. Coming back to cloning, you can also clone your horse. There is a company in Spain, horse.
Yeah. So.
In Spain called Ovoclone.
Yeah.
So the cloning.
Ovocloning, yes.
So you can imagine that there's probably a lot of money in cloning in high genetic merit stallions. So back to the subject, because the future is coming fast, and as you said, the possibilities are endless. The scientific world must have quick reflexes in trying to regulate these new technologies before they are actually at our doorstep. Because if we are slow, then it's too late. For example, the HFA has a so-called Horizon Scanning Group. So they meet once a year at ESHRE, and they invite experts from around the world, and they discuss future technologies that are not yet applied. So this is a very good example of how we, as a scientific expert, should react to this coming new interventions. For example, PRS is something that raises many ethical dilemmas, and there is no clear line what's right and what's wrong. So definitely we have to present quick reflexes to involve other disciplines, ethics, and I don't know who else, in order to be there and to be ready to address these challenges?
So one of the drivers of technology is the direct-to-consumer testing, DTC. Horses, goats, and ships are not DTC. These are companies. The cats and the dogs is direct-to-consumer. The same is true now for genetic testing. It's direct-to-consumer. So a patient may come to you and say, well, I had my exome done, and I just want you to explain it, and I don't want my baby to have that. And you haven't been involved in the whole process at all. So we have to, I don't want to use the word regulation. Inherently, as an American, I don't like regulations. As a Greek, I don't know what I like. But as an American, I don't like regulations. So this is not about regulating. This is about, as you said, preempting, preventing. So we have to prevent. We have to acknowledge the fact that right now there is direct-to-consumer testing for everything. There is direct-to-consumer testing, my other specialty is endocrinology. And for many years, endocrinologists complained about the inappropriate use of cortisol measurements for the measurement of stress, right? But the problem was that patients could not get cortisol measurements unless they went to their physicians. Well, no more. In Canada, they just got approval for direct-to-consumer testing your cortisol. There's a company, sends you a saliva kit collection, you send it in, and you have midnight cortisol and morning cortisol, and they interpret it for your stress level. And then, you know, what are physicians going to do? So you have to prevent that. Instead of saying, oh, you can't have cortisol testing, it should be done only by doctors. Don't do that. Accept the fact that anybody can do anything they want, but with education and with certain limits. That's all I'm saying.
Well, I think there's a difference between measuring your cortisol and discarding an embryo because
Completely agree.
it might have a non-life-threatening disease, for example.
That we expect to happen in the future very soon. And it made me realize that, I think you emphasized it as well, that it is important as we're trying to get answers from all these studies to really notice the design, to have very good design and get the right interpretation of the results. For example, as I'm coming from the PTT world, looking at the PTT study, the euploid embryos were born from the aneuploid transfer. It just made me wonder, maybe I got it wrong, and please correct me. We had some embryos that were assessed in 2017, and with an old software, they were monosomies, they could well be mitotic. And the reviewers did not ask for investigation of the root cause, for example, by haplotyping and comparing the postnatal sample to the biopsy sample. So I just wanted your view and your opinion on the studies, how are these published, and what we should look out for when we assess some results.
Yeah, well, now you're touching on another issue, the issue of review of publications. And unfortunately, again, we don't have good reviewers for most studies. And so you see things published that are, I see a lot of things being published that are inappropriate, basically. Mm. And that is because there's nobody captures, first of all, the lack of knowledge on behalf of the reviewers, and then the lack of proper editing process on behalf of the editors. So, yeah, I mean, I think I answered that. There is a lot of things that are being published that you cannot use as the golden standard.
Thank you. Thanks.
Yes.
Thank you very much. A last comment, and this will be the final comment of the Congress as we reach the end. And yesterday I started in the opening with some words of Yuval Harari, saying that by communicating with a dialogue, with a conversation, this made and still is making the progress. I will finish with the other book. This was from Homo sapiens, with from the book of Homo Deus, saying that, okay, who is going to taking the decisions tomorrow about eugenics and whether we will apply all this or not, us or AI? And with this, a bit philosophical, I would like to thank you, all of you, for being here until this late time. Να σας ευχαριστήσω και στα ελληνικά και εύχομαι να κερδίσατε κάτι από αυτό το διήμερο και ελπίζω ότι με τη συνεργασία όλων μας θα επαναληφθεί και του χρόνου και θα γίνει, νομίζω, θεσμός.